welcome all to the today's guideline. So, management of thyroid disorders in pregnancy, Green Top Guideline number 76. The further next subsequent part of this guideline, the pre-pregnancy management. Okay, now different conditions of the thyroid we will see in this particular section. Okay, so if there is overt hypothyroidism or severe subclinical hypothyroidism. Okay, these concepts you please understand. What do you mean by overt hypothyroidism? In overt hypothyroidism, what is going to happen? There will be decrease in FT4 level and there will be increase in TSH level. And in severe subclinical hypothyroidism, what is the situation? There is a TSH which is more than 10 milli international unit, but there is a normal FT4. So it is a subclinical. So FT4 level is normal, but it is a severe subclinical. That means TSH is more than 10 milli units per ml. Okay. So overt, there will be TSH will be increased, FT4 will be reduced. While in subclinical hypothyroidism, severe subclinical, the FT4 will be normal, but the TSH will be more than 10 milli units per and less than 10 will be non-severe subclinical hypothyroidism. Okay, so these are the indications for the treatment of the condition. Okay, so if you have got a overt hypothyroidism or if you have got a severe subclinical, that means TSH more than 10, but the FT4 is normal, you go for treatment. So goal for the before conception is a TSH less than 2.5 milli units per liter. Okay, so when the patient is presenting in the pre-pregnancy period, either she will be overt hypothyroidism or severe subclinical hypothyroidism, you have to go for treatment. Is this clear, doctor?
Yes, sir.
Yeah. So the next concept. Now the pre-pregnancy management of subclinical hypothyroidism. Okay, we have seen severe subclinical here. Okay, now you have got a subclinical hypothyroidism. TSH is increased, but level is less than 10. Okay, and T4 is normal. Here you consider the treatment. Here you definitely go for the treatment when you have a severe subclinical hypothyroidism. But if you have got only subclinical hypothyroidism where TSH level is less than 10 but more than normal range given, but FT4 is normal, you consider the treatment. And if there is a TPO antibody positive, that becomes a stronger indication for the treatment. Okay, so guideline says you definitely treat if it is more than 10. You consider the treatment if it is less than 10 but more than the specific range, but FT4 is normal, that is just subclinical hypothyroidism. But if it is a TPO antibody positive, you consider with a stronger indication. Is this clear?
Yes, sir.
Okay. So they have just divided this into severe and only plain subclinical hypothyroidism. And here they are saying treat definitely. Here they say consider treatment, but more stronger indication if she has got a TPO antibody positive. Okay. And what will be your target? Target will be to bring the TSH level to less than 2.5 milliunit before conception. Okay. So when the patient is presenting before conception, these are the things which you need to look into it. Then management after confirmation. Now this lady has become pregnant. What you are going to do? Okay. So levothyroxine dose adjustment. Okay. So hypothyroidism you have started LT4. Okay. So what you are going to do? Woman should self-initiate dose increase immediately after positive pregnancy test. Okay. So if she is uh, on treatment, she should increase the dose on her own immediately after the positive pregnancy test. And what she should do, double the dose of levothyroxine on 2 days per week. So out of 7 days she is taking this, any 2 days she can double the dose. Okay, this is the thing which she should do. Then monitoring during the pregnancy. How frequently you have to monitor? Every 4 to 6 weeks until 20 weeks. And at 20 weeks, you will have to repeat this particular test. So you will monitor FT4 and TSH because there are many fluctuations which are happening in the first half. So first half you require proper monitoring every 4 to 6 weeks until 20 weeks. After that, you just have to repeat at 28 weeks of gestation. Okay. Then treatment target will be TSH. You should be able to target less than 2.5 milliunits per ml, and FT4 should be within the trimester and manufacturer specific normal range. Okay, this is what you should do when the patient presents to you in a pre-pregnancy state. She is either subclinical hypothyroidism which is severe, or it may be overt hypothyroidism, definitely you will treat. Okay, subclinical you will consider. Subclinical with TPO antibody, stronger indication. Okay, then once you have started on FT4, what will you do? If she becomes pregnant, she will double the dose on any 2 days. Then you will monitor her TFTs. First half 4 to 6 weekly. Then you will repeat at 28 weeks, and you will keep the target level of TSH less than 2.5, and FT4 should be within the trimester and manufacturer specific ranges. Okay. Now subclinical hypothyroidism during the pregnancy. Okay. Now subclinical hypothyroidism, that means TSH is increased and FT4 is normal. So you have got a TSH which is between the upper trimester specific limit, but up to 10 milliunits per liter, but FT4 is normal. Levothyroxine should be considered in these particular cases, and especially in the first trimester. Okay. Initially, when she came to us in the pre-pregnancy period, we said consider. Okay. But if she becomes pregnant, she is a subclinical hypothyroid, and TSH level is less than 10 units milliunit per liter, then management is a levothyroxine should be considered. And this is the, especially in the first trimester, newly diagnosed in the first trimester, you will treat this with the levothyroxine. Okay, please remember this. Okay. Then next, about the TPO antibody. Do not routinely test the TPO antibodies when the woman is euthyroid. Okay, if the lady is euthyroid, we will not go ahead with the testing with the thyroid antibodies. So treatment based on thyroid antibody, levothyroxine is not recommended. Only presence of TPO antibody, don't. If she is euthyroid and TPO antibody is positive, there is no need to treat. Okay. If TPO antibody is positive, but if the patient is having no thyroid dysfunction, don't treat. Monitoring in TPO antibody positive women. If known TPO antibody positive, and if she is euthyroid, then what you should do? You will not treat, but you will monitor. Then how frequently you are monitored? The first trimester TFT we will do, and at 20 weeks also we are going to do, because here the patient is euthyroid. Okay, because here the patient is euthyroid, we will just repeat the TFT in the first trimester and again at 20 weeks of gestation. Purpose is to detect the development of hypothyroidism. Okay, so TPO antibody is positive, she is euthyroid, no treatment is required, but monitoring is required. And here monitoring is first trimester TFT and 20 weeks TFT. Okay. Now we will go for the hyperthyroidism preconception. Now she has come to us in the preconceptional period, but there is a hyperthyroidism. What is the drug of choice? It is the PTU, that is propylthiouracil, that is preferred. Carbimazole is to be avoided as far as possible. Okay. And you use lowest effective dose. Target will be FT4 in the upper half of the reference range. Okay. Now you have got a hyperthyroidism, and she is in early pregnancy. First, what we have seen, pre-pregnancy hyperthyroidism, and she wants to conceive, we will go for propylthiouracil. Okay. So hyperthyroidism and early pregnancy, discontinuation of the antithyroid drugs will be considered only if, okay, she is already hyperthyroid and she is presenting in early pregnancy. In this case, you will consider antithyroid stopping if she is euthyroid for more than 6 months and she is on a very low dose of antithyroid dose. Then you may discontinue this particular medicine. Okay, but monitor closely. Okay, so otherwise, what you are going to do? If she is not fitting these criteria, that euthyroid for more than 6 months and low dose of antithyroid, then what is the scenario? She will require the antithyroid drug. But if she is conceived on carbimazole, then we will switch to propylthiouracil as early as possible and before the 10 weeks of gestation. Okay, so you check the medicine which she is taking, check the dose which she is taking. If she is euthyroid for more than 6 months, low dose of antithyroid, then you will stop the antithyroid. But if she is going to require, the dose is high, in that you will know the which medicine she is taking. If she is taking carbimazole, then we will change it to the PTU as early as possible and before 10 weeks of gestation. Okay, so remember, early pregnancy, PTU is the drug of choice. Okay, then how frequently we should monitor these patients? If she's hyperthyroidism, in the first half, every 2 to 4 weeks, and after 20 weeks, 4 to 8 weeks. Because in the first half, lots of changes which are happening with the thyroid gland function. So we should monitor these patients more frequently, that is 2 to 4 weekly, and after 20 weeks, monitor 4 to 8 weeks. Okay, and which test you are going to monitor? TSH and FT4. Okay, so treatment target will be adjust antithyroid drugs to maintain FT4 should be in the upper half of normal trimester specific range. Okay. Now, differentiation of thyrotoxicosis. When you have a thyrotoxicosis, you should be able to differentiate from gestational transient thyrotoxicosis, that is GTT, from the Graves' disease. Okay. So what happens? What will be the presentation? Presentation will be TSH will be low and FT4 will be increased and the patient is pregnant. But you have to differentiate this from the Graves' disease and the GTT. Okay. Now, what is going to happen if she is having the Graves' disease? It is not only FT4 will be increased, but it will be FT3 will also be increased. That will be uh, a disproportionate increase in the FT4 will, FT3 will also be there. There will be clinical features, and the most important will be TRAB, thyroid receptor antibodies will also be positive. So when you have this particular thing that she is pregnant, she has got a low TSH, she has got FT4, then you will do the FT3 also, you will do the TRAB, you will look into the clinical features, then you will diagnose the Graves' disease. And in gestational transient thyrotoxicosis, what is going to happen? The FT3 increase will be just mild increase. There will be no disproportionate increase. TRAB will be negative and clinical features may not be there. You got it? So that is how when the patient presenting with increased FT4 and reduced TSH, you have to differentiate these two conditions. So you will carry out TRAB, FT3, you will look into the clinical features. Okay. Now, if you have got a gestational transient thyroid toxicosis, no antithyroid drugs are required. If the patient is symptomatic, only supportive care is to be given. Okay, so what we have seen, preconceptional hypothyroidism and overt preconceptional hypothyroidism and the overt hypothyroidism, what you are going to do. Then hyperthyroidism, how we are going to treat pre-pregnancy and during pregnancy. That is what we have seen in this section. Okay, so this finishes this thyroid hypothyroidism and hyperthyroidism part. There are further few things that we'll see in the subsequent section. Doctor, can you please read these questions on the topic which we have just discussed?
Yes, sir. A 29-year-old woman is planning pregnancy. She asks about iodine intake. What is the recommended total daily iodine requirement during pregnancy? A 100 microgram, B 150 microgram, C 200 to 250, D 300, and E 500. It is C 200 to 250 microgram.
Yes, that is recommended iodine intake. Pregnancy and breastfeeding is around 200 to 250 microgram, 150 micrograms of potassium iodide if supplementation. Okay, next.
Pregnant women with low dietary iodine intake ask about supplements. What is the recommended supplemental iodine dose? It is C 150 microgram.
150 microgram. Okay, supplemental dose should be 150 microgram used to achieve the total intake of around 200 to 250. Next.
A 32-year-old prime gravida presents at 8 weeks. She has no risk factors for thyroid disease. What is the most appropriate screening approach? No routine screening is required. B.
B, correct. So only targeted screening. Okay, targeted screening only in high risk women. So timing as early as possible for targeted patients, preferably first trimester. Next.
A high-risk pregnant woman presents for booking. When should the thyroid function testing ideally be uh, performed? A. Preconception only. B. First trimester. C. Second trimester. D. Third trimester. E. Postpartum. B. First trimester. As soon as he presents to
Yes,
us.
first trimester. Preferably in the first, as early as possible, preferably in the first trimester. Next.
A woman with known overt hypothyroidism is planning pregnancy. What is the recommended preconception TSH target? It is less than 2.5 milliunits per liter. B.
Yes, B, less than 2.5 milliunits per liter. So for what? hypothyroidism and severe subclinical hypothyroidism where TSH is more than 10, then TSH target is less than 2.5 preconception. This subclinical hypothyroidism concept, I hope you have understood.
Yes, sir.
FT4 is normal. In that also there is subcategory of severe subclinical hypothyroidism, which is a mandatory treatment. Okay. Other cases consider the treatment. But if that also TPO antibody positive, that is a stronger indication.
Strong
Next.
indicator. A woman has TSH 12 million units per liter with normal free T4 pre-pregnancy. What is the best management? A. No treatment. B. Observe and repeat in 6 months. C. Start levothyroxine. D. Start iodine only. E. Refer postpartum. C. Start levothyroxine.
So what is the concept here?
It is severe subclinical hypothyroidism,
Yes,
and her
yes.
TSH should be brought to less than 2.5.
Correct.
Okay.
Okay, severe SCH, TSH more than 10 milliunits per liter. Treat like overt hypothyroidism, TSH you have to bring it to less than 2.5. Okay, next.
A woman planning pregnancy has TSH 6 million units per liter with normal free T4 and TPO antibody positive. What is the best management? A. No treatment. B. Start levothyroxine. C. Start iodine only. D. Repeat after delivery. E. Start antithyroid drugs. It is B. Start levothyroxine.
So what is the concept here?
She's TPO antibody positive with non-severe subclinical hypothyroidism.
Correct. That is
Still, we
a
need to
stronger indication for treatment. Okay, start LT4 for SCH less than 10 plus TPO antibody positive. Consider treatment and TSH target same less than 2.5. Next.
a woman on levothyroxine becomes pregnant. What is the recommended immediate action? Continue same dose, reduce the dose, double daily dose, double dose on 2 days per week. Stop levothyroxine. It is D, double the dose on 2 days per week.
Correct. Okay. So self increase in the LT4 dose immediately, double dose on 2 days per week. Next.
A pregnant woman on levothyroxine is being followed up. How often should thyroid function test be checked until 20 weeks? A weekly, B every 2 weeks, C every 4 to 6 weeks, D every trimester, E only once. It is C every 4 to 6 weeks till 20 weeks.
So
Then at
till 20,
28 weeks.
yeah, every 4 to 6 weeks until 20 weeks, then once at 28 weeks. Okay. Next.
After 20 weeks of gestation, when should thyroid function be checked again? It is C 28 weeks.
28 weeks. Okay. Same thing. Next.
A pregnant woman is on levothyroxine is being monitored. What is the target TSH? It is less
TSH
than
target.
2.5.
Correct. Less than 2.5, doctor. Okay.
2.5.
TSH should be less than 2.5. FT4 should be within normal trimester specific range. Okay. Next question.
A 30-year-old primigravida presents at 8 weeks. TFT shows TSH of 6.5 and normal free T4. She has no prior thyroid disease. What is the most appropriate management? Reassure and repeat TFT at 20 weeks. B. Start her on levothyroxine. C. Check TPO antibody before deciding the treatment. And D. Start iodine supplementation only. E. No treatment unless TSH is more than 10. C. We need to check the TPO antibody
Oh,
before deciding.
what is her thyroid status?
Her thyroid status is non-severe subclinical
No
hypothyroidism.
prior thyroid disease. Okay, then old primary gravida TFT shows TSH of 6.5, FT4 is normal. Okay, elevated for this particular range. What is the most appropriate management here? She
It's
doesn't.
actually no treatment is required, sir, but
Why no
should we
treatment
not
is
check
required?
because she's a non-severe
First
subclinical?
thing, first and foremost thing is that why the TFT is done for this lady. TFT, do we do the
Yes,
screening
sir.
for all? She
No,
must be
she's an
having
high
some
risk.
fact. maybe some history, some kind of history is there, either obstetric history will be there or on clinical examination, etc., etc. We have seen 5-6 indeed. Then TFT is there. Then TFT shows TSH is increased, but FT4 is normal. So what we are going to label this as a subclinical
Subclinical hypothyroidism.
hypothyroidism. Now, if she is a subclinical hypothyroidism, then what? Do we have to go for, and she is euthyroid per se. Otherwise, there are no other features. They have not given any features. Okay.
Yes, sir. If she's euthyroid and non-severe, there is we have to just consider treatment, but we don't start her on
That is in the pre-pregnant
euthyroid.
state. That is in the pre-pregnant
Okay,
state.
okay.
Now she is in the pregnancy with
Mhm.
8 weeks of pregnancy. Okay.
Then we'll start her
So
on
we should start with the levothyroxine.
levothyroxine. Yes,
Okay.
yes.
So start levothyroxine. SCH during the pregnancy, TSH is increased, FT4 is normal. Levothyroxine should be started. Stronger indication if newly diagnosed in the first trimester. Okay,
Okay,
okay.
sir.
You understood the difference now.
Yes, sir.
Okay,
A
next.
27-year-old woman at 10 weeks has normal TFT. She requests thyroid antibody testing due to anxiety. What is the best next step? Test TPO antibody routinely. Test TRAB instead. Reassure and do not test TPO antibody. Start levothyroxine. Repeat TFT in 2 weeks. We need to see reassure her not to test TPO antibody.
Reassure and do not test TPO antibody. Routine TPO antibody testing is not recommended in euthyroid women. Next.
A 32-year-old woman at 9 weeks is a known TPO antibody positive with TFT is normal. What is the most appropriate management? A. Start levothyroxine. B. Start PTU. No treatment, routine antenatal care. D. Monitor TFT at first trimester and 20 weeks. E. Repeat TFT weekly.
So TPO antibody positive, normal TFT.
Euthyroid, they
Treatment.
don't require treatment, but we
So
need
first
to
thing is
monitor.
treatment is not required.
Not
Next
required.
question will be monitoring. Will
Monitor.
she require monitoring? Monitoring will be required. Then how
Yes, sir.
frequently?
D.
First trimester and 20 weeks
20
gestation.
weeks. D.
Okay.
It is D.
Yeah. And thyrotoxicosis requires more frequent repeating. Okay. Here it
Yes.
is TFT first and 20 weeks. Okay. So monitor TFT at first trimester and 20 weeks. TPO antibody positive plus euthyroid. No levothyroxine is required. Monitor TFT first trimester and 20 weeks. Next.
A 35-year-old woman at 11 weeks is TPO antibody positive with normal TSH and pre T4. What is the best management? A. Start levothyroxine to prevent miscarriage. B. Start iodine only. C. No levothyroxine required. D. Start carbimazole. E. Repeat TFT at 36 weeks. C. It is C. No
Yeah, here
levothyroxine.
this is the best option because there is no, they have not mentioned about the test. Okay, next.
Woman with Graves' disease is planning pregnancy. She's on carbimazole. What is the most appropriate preconception management? A. To continue carbimazole. B. Switch to PTU. C. Stop all treatment. D. Add levothyroxine. E. Delay pregnancy indefinitely. It is B. Switch to PTU.
Correct. So we'll switch her to propylthiouracil. While trying to conceive, P2 is preferred over carbimazole. Use lowest effective dose. FT4 should be in the upper normal range. Next.
A 29-year-old woman with hyperthyroidism becomes pregnant. She has been euthyroid for 8 months on low dose PTU. What is the best next step? Increase PTU dose, continue the same dose, stop PTU with close monitoring, switch to carbimazole, add levothyroxine. It is C to stop PTU with close monitoring.
Why? What is the concept
He
here?
has been euthyroid for more than equal to 6 months on lowest low dose PTU.
Yeah, then you can stop the PTU with close monitoring. Okay. Stop PTU with close monitoring because you thyroid for more than 6 months and low dose is required. Next.
Woman on carbimazole conceives and presents at 7 weeks. What is the most appropriate management? A. Continue carbimazole. B. Stop all drugs. C. Switch to PTU immediately. D. Wait till 12 weeks, then switch. E. Add iodine. It is C. Switch to PTU immediately.
Correct, correct. Okay, so if conception occurs on carbimazole, switch to PTO as early as possible. Must be done before 12 weeks of gestation. Next.
A pregnant woman on PTU is at 12 weeks gestation. How often should the TFT be monitored? A. Weekly. B. Every 2 to 4 weeks. C. Every 6 to 8 weeks. D. Once per trimester. E. Only with if symptomatic. It is B. Every 2 to 4 weeks.
Yeah, so thyrotoxicosis patient, first half more frequent. Okay,
Yes,
second half less frequent. So
less
first half 2 to 4 weeks, second half 6 to 8 weeks. Okay, first half every 2 to 4 weeks. Next.
At 26 weeks gestation, how frequently should the TFT be monitored in a woman on antithyroid drugs? A. Weekly. B. Every 2 weeks. Every 2 to 4 weeks. Every 4 to 8 weeks. E. Once only. Yes. D. Every 4 to 8 weeks.
Correct, correct. Okay, after second half it is 4 to 8 weeks. Next.
A pregnant woman on P2U has borderline high free T4. What is the treatment target? Free T4 normal, free T4 mid normal, free T4 upper half of the normal range, suppressed TSH, undetectable TSH. It is a free T4 upper half of the normal range.
Yes. So if you have got a hypothyroidism, which requires LT4 treatment, levothyroxine, you will go for TSH. Okay, you will target the TSH below 2.5 or the pregnancy specific, and that should be in the lower half of the range, normal range. Okay,
Yes,
if you have got a hyperthyroidism,
hyperthyroidism.
you will monitor FT4 and it should be in the upper half of normal range. You got it?
Yes, sir.
Okay, next.
A 10-week pregnant woman has suppressed TSH, elevated free T4. What is the most appropriate investigation to differentiate Graves' disease from gestation transient thyrotoxicosis? A. Anti-TPO antibodies. B. Serum calcitonin. C. TRAB and free T3. D. Thyroid ultrasound. E. Radioiodine uptake. It is C. Thyroxine receptor antibody and free T3.
Yes, TRAB and FT3 that will differentiate between the Graves and the GTT. Okay, because that will be increase. There will be disproportionate increase in the FT4 and TRAB will be positive. Okay, next.
Yes. Woman at 9 weeks has hyperemesis with suppressed TSH and mildly elevated free T4. No goiter. TRAB is negative. What is the best management? Start PTU, start carbimazole, start levothyroxine, symptomatic and supportive care, E thyroidectomy. It is D symptomatic and supportive care.
Because it is a GTT. Okay, GTT does not require specific treatment. Treatment is only symptomatic and supportive. Okay,
Yes.
no antithyroid drug required. Next, we have got few EMQ doctor. So this is the first scenario.
Yes. A 28-year-old primary gravida presents at 7 weeks. TFT shows TSH is 7.2 million units and free T4 is normal. She has no prior thyroid history and was not tested pre-pregnancy. What is the next best step?
Just understand the question, come to the
Yes,
diagnosis, and then the concept.
options.
And what you have understood from this
She is
first,
a case of subclinical hypothyroidism
when
during her first trimester.
first
Now
trimester. Okay,
she'll be started on levothyroxine.
any other more better than is there, that also we need to check. Okay, always
Yes, sir.
when first you go for this, write what you feel, then you see anything better than that. That is the second step. Okay, so is there anything which is better than that? No, I think that is the one.
No, sir.
Okay,
It
so
is A, sir.
A. Okay, next question.
31-year-old woman at 9 weeks is a known TPO antibody positive from previous evaluation. Current TFT is normal. She is asymptomatic. What is the most appropriate management? Sir,
She is
option.
yeah,
She
what is her
is
status?
TPO. antibody positive, but she's euthyroid, so we
Euthyroid.
don't
So,
start her on any treatment, but she needs close monitoring.
okay.
Monitoring her TFT every 2 to 4 weeks, 4 to 8 weeks.
Is it?
No, sorry, sir. It is B. Do not start levothyroxine. Monitoring in first trimester and at 20 weeks
Correct.
for
Okay.
development of hypothyroidism.
Yeah. More frequent monitoring with thyrotoxicosis. Okay.
Thyrotoxicosis.
Here she is just TPO antibody positive, but euthyroid. Okay. No levothyroxine, but TFT monitoring in the first trimester and at 20 weeks.
Yes, sir.
I hope the concepts are getting cleared. Okay.
Yes, sir.
Next.
A
This third.
34-year-old woman with Graves' disease conceives while on carbimazole and presents at 6 weeks of gestation. She is clinically stable. What is the next best step? Because she's in first trimester Graves' disease, we'll shift her to PTU. And we need to increase our monitoring. During first trimester till
Yeah.
20 weeks, we'll go for 2 to 4
So
weekly.
what is the option?
T switch carbimazole to PTU immediately.
Option
D, sir.
D. Okay. See, here is another option, start PTU. So when you just look at, haphazardly, no, you read, go through all options. Okay.
Yes.
And whatever is best, no, then you select. These are a few mistakes which happen when you solve SBA. Even if you know the correct answer, it should be correct as well as best. Okay.
Yes, sir.
So,
A 26-year-old
mm,
woman at 10 weeks presents with hyperemesis. TFT shows suppressed TSH and mildly elevated 3T4. She has no goiter, no eye signs. What is the most appropriate next step? This looks like a case of gestational transient thyrotoxicosis. So we'll have to give it symptomatic and supportive management only. K.
option K.
K.
Correct. Okay.
A, B, D, and K.
So, A, B, D, and K. Okay. So
Yes,
that
sir.
is, uh, so this we have seen, same concepts are being repeated. So I will not read that because we have solved the SBAs on those concepts. Okay.
Okay, sir.
So just take home message that iodine 200 to 250 microgram per day requirement. Supplement is around 150 microgram potassium iodide. Screening is only targeted, and that should be done in the first trimester. Preconception target TSH should be less than 2.5. Severe subclinical hypothyroidism. Treat if TSH is more than 10. Mild subclinical hypothyroidism plus TPO antibody positive. Consider treatment. Levothyroxine dose increase immediately. 2 days per week you will increase, and monitoring 4 to 6 weeks till 20 weeks, and at 28 weeks for hyperthyroidism. Then target TSH should be less than 2.5 milliunits. Okay. And always use trimester specific, SA specific, TSH and FT4 ranges. Iodine requirement, we have seen targeted screening first trimester preconception goal. We have seen increase LT4 immediately after positive test. Monitoring 4 to 6 weekly till 20 weeks, and at 28 weeks maintain TSH below 2.5. Subclinical hypothyroidism, consider LT4 especially in the first trimester. Okay, if you get subclinical hypothyroidism in the pregnancy, you will treat this. Do not screen TPO antibody. TPO antibody plus euthyroid, no LT4 is required. TPO antibody plus euthyroid, monitor at first trimester and at 20 weeks. Okay. Preconception hyperthyroidism, PTU is preferred. If stable, consider stopping ATD in early pregnancy. More stability should be more than 6 months, and low dose of ATD required. Okay. Carbimazole, switch to PTU before 10 weeks. Monitoring of antithyroid 2 to 4 weekly in early and 4 to 8 weeks in the latter. Target FT4 should be in the upper normal range. Suppress TSH plus increase FT4. Then you will check TRAB and FT3 to differentiate it from the Graves disease and the GTT. Okay. GTT treatment is only supportive, no ATD. So that finishes the this particular section of this particular guideline. Okay. Now we have got a overt hypothyroidism and severe subclinical hypothyroidism. This we have seen in overt hypothyroidism, TSH is increased, FT4 is reduced. So in severe SCH, TSH is more than 10 and normal FT4. These are the conditions which require treatment. And the target also we have seen it should be less than 2.5 preconception. Okay, these, and if it is a subclinical hypothyroidism, TSH is less than 10, but normal FT4, we will consider levothyroxine and stronger indication with TPO antibody positive. Again, the target will be less than 2.5. Okay, now sometimes we may get isolated low FT4, okay, but the TSH is normal. Okay, so these cases will require a referral to endocrinology. Purpose is to exclude secondary hypothyroidism or the pituitary disease. This you remember, because if you have got a low FT4, okay, TSH is normal, but FT4 is low, then you will require endocrinology referral. So this is different from this. Okay, here TSH is increased, but the normal FT4 is there. You have done, we always do TSH and FT4. Okay, but here TSH is normal, but the FT4 is low. Then these patients will require referral to endocrinology to exclude the secondary hypothyroidism. Now, levothyroxine dose increase in when immediately after the positive pregnancy test, the dose is to be increased. It will be self by the patient. Okay, then what are the options which are available? One, first option is that double the dose on any 2 days per week. Second, if her baseline dose is less than 100 microgram or equal to 100 microgram, then daily you increase it by 25 microgram. Or if her dose is more than 100 microgram baseline dose, then you increase 50 microgram per day. Or she can increase herself by 2 days in a week. Okay. So overall increase is around 25 to 30%. Okay. So monitoring and titration in pregnancy till 20 weeks, every 4 to 6 weeks, and after that repeat at around 28 weeks of gestation. Okay, we'll do the TSH and FT4 for these patients. Okay, so she is hypothyroidism requiring LT4, becomes pregnant, we'll increase the dose. At any 2 days, she can double the dose, or if baseline dose is less than or equal to 100, increase is 25 microgram. Baseline dose more than 100, increase 50 microgram per day. Okay, and then monitor till 20 weeks, every 4 to 6 weeks, and after that 28 weeks. And these are the tests which we are going to do. Target is less than 2.5. Okay, FT4 should be within the trimester specific range. TSH should be in the lower half of the reference range. She is a hypothyroidism, so TSH is the test and it should be in the lower half of the reference range. Okay, now postpartum, what we are going to do? If she is on LT4 pre-pregnancy, then you go for preconception dose. Okay, and you should do this within the 2 weeks postpartum. Okay, so now in the lactation period, because we know what are the changes. The first section of the guideline, if you remember the changes which are happening, okay, and you compare now in the postpartum period, there is a decrease in the requirement. So you go for the preconception dose, and that should be done within 2 weeks postpartum. So women who were hypothyroidism before pregnancy should return to their pre-pregnancy levothyroxine dose soon after delivery as the increased physiological demand resolves. Okay, this is the concept we should remember. Now, if LT4 is started during the pregnancy, so first situation was that she has started the LT4 before she was already hypothyroidism. Now, if we have started the LT4 during the pregnancy, stop after the delivery, but check the TFT 6 weeks postpartum. Okay. So if she is before pregnancy on thyroxine, during pregnancy we will increase the dose, but within 2 weeks of the delivery, we'll come back to the pre-pregnancy level. Now, if you have started LT4 during the pregnancy, you will stop after the delivery and you will repeat TFT at 6 weeks of gestation, postpartum. Okay. Then what about the thyroid antibodies? Screening, routine thyroid antibody screening is not required. Okay. So TPO, if she is TPO positive, then we will monitor the TFT. Okay. In the first trimester and at 20 weeks. Okay. To detect the progression. So if she is euthyroid, then no levothyroxine is required. If she is TPO antibody positive and euthyroid, no LT4 is required. Okay. Now, if she is a case of Graves' disease, pre-pregnancy counseling is must. Okay. Now she has got a Graves disease. That means she will be antibody positive also. She will be on LT4 also. Now, what is the most important in this patient is the pre-pregnancy counseling. This is essential, and she should be euthyroidism early before she conceive. Okay, so in preconception, what are the options for her which are available? One, she will be going for radioiodine or surgery, and third, she will be on medications, okay, depending upon that particular condition. So if she's on radioiodine or surgery, that will be considered only in severe disease. If she undergoes radiotherapy treatment especially, then conception is to be delayed for 6 months at least, or 6 or more months after the treatment, then she can go for conception. Okay, require, because that much time is required for the FT4 to become normal, and she should have at least two tests 3 months apart. So she should do two tests which are 3 months apart. She should delay the conception for 6 months. Okay, now if she has got a TRAB level more than 3 times of the normal, there is an increased risk of the fetal Graves disease, and consider delaying the pregnancy. So if pre-pregnancy, if her TRAB levels are more than 3 times of the normal, then there is an increased risk of the fetal Graves disease. So she should consider delaying the treatment. Now, what about the antithyroid drugs preconceptionally? Propylthiouracil is preferred, and carbimazole is to be avoided. Lowest effective dose should be, and target should be FT4 in the upper normal range. Okay. Now, if she is a case of Graves disease in the pregnancy, preconception, what we have seen, preconceptional counseling, the dose adjustment, and the type of treatment, and accordingly the advice. These are the things in the preconception. Now, if she is pregnant, then what about stopping the antithyroid drugs? If she's euthyroid for more than 6 months and low dose antithyroid, then we will stop but go for monitoring. Okay. Drug choice, early pregnancy is a propylthiouracil. On carbimazole will switch before 10 weeks to PTU. Ratio should be 1 is to 20. That means if she is on 5 milligrams of carbimazole, we will start on 100 milligrams of propylthiouracil, because it is little weaker drug. Okay. So after 10 weeks of gestation, there is no benefit of switching. Okay. So when switching from carbimazole to PTU in early pregnancy, use a 1 is to 20 conversion, meaning PTU dose is approximately 20 times the carbimazole dose. This also you remember maybe from SBA point of view. Then how frequently you will monitor? Thyrotoxicosis, more frequent monitoring in the first half, 2 to 4 weekly, after 20 weeks, 4 to 8 weekly, and after changes. Once if you have changed the dose, then you will have to monitor every fortnightly. Okay. So thyroid function should be monitored every 2 to 4 weeks in early pregnancy due to rapid physiological changes, then less frequently after 20 weeks as stability is achieved, with more frequent testing after any dose adjustment. So if you do the dose adjustment, then fortnightly. Okay. So target FT4 should be in the upper half of the that pregnancy specific range. Okay. Then TSH may remain low, rely on FT4. What about the fetal? You have to do the fetal monitoring also. Indications will be uncontrolled Graves disease if the patient is on antithyroid drug, or if she is having a TRAB level more than 3 times. Okay. So you will do the monthly ultrasonography, and Doppler you will do around 6 to 28 weeks of gestation, and TRAB monitoring is required in the first trimester. You will check the TRAB level. If positive, or if she is on antithyroid drug, you will repeat at 20 weeks and at 28 weeks. So uh, TRAB antibody you have to check in the first trimester also, and if positive, or if she is on antithyroid drug, you will repeat at 20 weeks and at 28 weeks also, because what is going to happen at 20 weeks, the fetal thyroid will start functioning, and once the fetal thyroid starts functioning, this TRAB antibody, if it is positive, they will get transferred to the fetus, and there will be fetal Graves disease. Okay. So maternal thyroid status does not reliably predict the fetal risk. Okay, so you have to repeat. First, you check the TRAB in the first trimester. If positive, or if she is on antithyroid drug, you will repeat it at 20 weeks and 28 weeks. This concept you have to remember, because at 20 weeks, the fetal thyroid will start functioning, and these TRAB, these are IgG type of antibodies actually. They will cross the placenta and they will have the neonatal effect. So for the neonatal care, what does the guideline says? You check the TFT one soon after the birth, then you repeat at 1 to 2 weeks. Okay. Now the concept of gestational transient thyrotoxicosis that we have seen, testing, do not test TFT only for the nausea or vomiting. Okay. So differentiation from Graves disease, this also we have noted there will be increase in the TRAB level and FT3 levels. Management of GTT is only supportive. No antithyroid drugs are required. Coming to the postpartum. Postpartum, suppose if she is a case of hyperthyroidism in the postpartum period, you will do the TFT at 6 to 8 weeks postpartum. Breastfeeding, PTU as well as carbimazole both are safe. Use the lowest dose. Okay, divide the dose in 2 to 3 times per day. That will reduce the amount of the drug which is getting transferred to the baby through the milk. Then suppose you get a thyroid nodule in the pregnancy. Once there is a nodule, we have to look for the compression symptoms. Okay, so initially you will do the TFT. You will also refer it to the specialist. You will also check the FNAC because FNAC is safe at any gestation. Okay, so this is not very common thyroid nodule in pregnancy, but if you get it, you will check the TFT, you will refer to the specialist, you will consider the FNAC which is safe at any gestation. Okay, the timing of the surgery for the nodule, it will be around second trimester, 14 to 22 weeks of gestation. You will also get the anesthetic review done if there is an enlarged thyroid. Okay, now if it is a thyroid cancer, there is no difference on the recurrence or the survival in the pregnancy. Suppose if you get a thyroid cancer, the pregnancy does not have any effect on the recurrence or the survival. Now, what about the postpartum thyroiditis? Okay, remember this particular concept. We have seen postpartum nodule. We have seen gestational transient thyrotoxicosis. Now we are talking about the postpartum thyroiditis. This postpartum thyroiditis is an autoimmune inflammation of the thyroid which is occurring within 1 year of the delivery and classically causing transient thyrotoxic phase followed by the hypothyroidism and followed by the euthyroidism. So it is a dynamic condition. It will develop post delivery within 1 year, and initially there will be transient hyperthyroid or the thyrotoxicosis phase followed by the hypothyroidism, and then the patient will become euthyroid also. Okay, so routinely you don't have to screen for this postpartum thyroiditis unless there are some suspicion. Okay, if symptomatic you will do the TFT. You have to do the serial TFT every 6 weeks. Okay, if the patient is thyrotoxicosis, you will also check for TRAB and consider the isotope scan. Okay, and remember isotope scan is safe during the pregnancy or the breastfeeding period. Okay, so postpartum thyroiditis is a self-limiting autoimmune thyroid dysfunction characterized by the transient thyrotoxic phase followed by hypothyroidism, diagnosed with the TFTs and managed symptomatically with long-term risk of permanent hypothyroidism requiring annual monitoring. Okay, so postpartum thyroiditis, there is a permanent risk of permanent hypothyroidism also in 50% of cases. Okay, and that requires annual monitoring. So if the patient is in the thyrotoxic phase, antithyroid drugs are not required, but you will treat them with beta blockers for symptoms. Okay, so postpartum thyroiditis happening within 1 year, she is in the thyrotoxic phase. So first phase you are detecting, antithyroid drugs are not used required, but beta blockers will be required. Okay, but if she is in a hypothyroid phase, then LT4 will be required if she is symptomatic or if she is planning pregnancy. Okay, if untreated, if she is not treated, then monitor her every 6 weeks. Long term, what is the risk? 50% will develop permanent hypothyroidism, and you need to check the annual TSH in these patients. For future pregnancy, for these patients, you will check the TFTs, preconception and early pregnancy. Okay, so prevention, there is no LT4, then iodine and selenium prophylaxis, they don't have any role. Okay, so that finishes the total guideline of thyroid and pregnancy. The GTG guideline is over. Doctor, we have few questions, doctor. Please go through it.
Yes, sir. A woman with known hypothyroidism is planning the pregnancy. What is the optimal pre-conception TSH target? It is D less than equal to 2.5 million units per liter.
Correct. So preconception target is less than or equal to 2.5 million units per liter.
Which of the
Next.
following meets the criteria for severe subclinical hypothyroidism? It is a CTSH11 with normal free T4,
Correct. Correct.
more
Okay.
than 10.
TSH11 and normal FT4. Okay. Next.
A woman planning pregnancy has low free T4 with normal TSH. What is the next step? Uh, Next step is to see refer to endocrinology.
Yes. Here, this is the only condition where the
Normal
endocrinologist, because
TSH
she has got a low T4 but normal
T4.
TSH. Okay. You got
Yes.
this particular point. Okay. Refer to endocrinology. And sometimes they pick up such small topic only and put the question. Next.
A woman on 75 microgram levothyroxine becomes pregnant. What is the best immediate adjustment? A. No change. B. Increase by 10%. C. Increase by 25 to 30%. D. Double daily doses. E. Stop and reassess. It is C. Increase by 25 to 30%.
Yeah. And there are three options for this. Okay.
Yes,
Overall, there will be increase by around 25 to
25
30%.
to 30%. A
Next.
pregnant woman on levothyroxine requires TFT monitoring. What is the correct schedule up to 20 weeks? It is C 4 to 6 weekly.
Okay. She is levothyroxine and TFT monitoring. Pregnant woman on levothyroxine,
C.
4 to 6 weeks. Yeah.
A woman on levothyroxine pre-pregnancy delivers. What is the next step? A. Continue same dose. B. Stop the levothyroxine. C. Reduce the dose by half. D. Revert to pre-pregnancy dose at 2 weeks. E. Check TFT immediately. It is D. Revert to pre-pregnancy dose at 2 weeks.
Yes. Okay. This is the difference. And if she has started during the pregnancy, what you are going to do?
We'll stop the dose and we'll check her TFT at 6 weeks.
Correct. Correct. Okay. So here you revert to pre-pregnancy dose at 2 weeks.
A woman started on levothyroxine during pregnancy. What is the correct postpartum plan? A. Continue lifelong. B. Stop immediately and check TFT at 6 weeks. C.
Yeah.
Reduce the dose gradually. Continue for 3 months. Switch to PTO. It is B.
Yeah.
Stop
Just now we
immediately and check
discuss. Yeah. Just
6
now we
weeks.
discuss. Next.
A euthyroid pregnant woman asks for a TPO antibody testing. What is the best advice? It is C. Not recommended route.
Yes. This we have discussed. Next.
A euthyroid TPO antibody positive pregnant woman is C. What is the correct uh, management? It is D. TFT should be done at first trimester and 20 weeks. Close
Correct.
monitoring is there, no treatment is required.
Yeah. So TFT you will do at first trimester at 20 weeks. Next.
A woman undergoes radioactive iodine therapy. When can she attempt conception? It should be delayed after 6 months. D option.
Yeah. 6. Next.
A woman on carbimazole becomes pregnant at 6 weeks. What is the next step? It is C to switch to PTU immediately.
Yeah. Before 10 weeks only, because after 10 weeks there is no change in the outcome.
Role of change
Yeah.
switch. A woman with postpartum thyroiditis presents with thyrotoxic symptoms. What is the best treatment? It is D beta blockers.
Yeah. Because you have to treat symptomatically here, these patients. Okay. So
Yes.
thyrotoxic phase, these ATDs are not indicated. Okay. Now we have got EMQs. Okay. These are the options. First EM.
Yes. A 29-year-old woman on levothyroxine 100 microgram as a positive pregnancy test. What is the next step?
She's already on thyroxine. The dose is
Thyroxine.
100 microgram. So
It is C, sir, to increase levothyroxine by 25 to 30%. Or another option is we can add 50 microgram per day on daily dose. But they don't
no,
have that. So
it's
25
less than or
micro
equal to 100 is 25. More
25,
than 100 is 50. Okay,
50.
you got it. So
Yes.
please do not get confused. So here the best option will be C. Okay. Next EMQ. Next.
A woman newly started on levothyroxine during pregnancy delivers. What is the next step?
She has delivered and she has started during the pregnancy.
It is to stop levothyroxine and check TFT at 6 weeks postpartum. F
F.
option.
Correct. Option F. Okay. Next.
A pregnant woman with Graves' disease has suppressed TSH and high free T4. Differentiation from gestational thyrotoxicosis is required. What investigation is done? It is TRAB and free T3 is
Yes,
done.
FT3 and TRAB you will do. So do you have any such options?
G
So
option is the closest.
closest will the major TRAB. So you are getting used to the EMQs now, very properly analyzing
Yes,
them.
yes.
Okay.
A pregnant
Mm,
woman has a
mm.
new thyroid nodule suspicious on ultrasound. What is the next step?
So thyroid nodule. Okay.
We'll do TFT.
Yes, TFTs are required. What else? What will be
Closest
thyroid
option is
nodule?
K to perform FNAC. They have not given TFT option. Given TFT every 4 to 6 weeks.
This option is also there. D is also there.
D.
Then system
K perform FNAC.
FNSC. Tissue diagnosis. Have they given any scheduled thyroid surgery? So K or D. These are the two options are the closest. And what is the question? We'll go back to the question. New thyroid nodules. It is suspicious on ultrasound. So I think once it is a suspicious, we'll go for FNSC. Perform FNSC. Okay, next.
Yes, sir. A woman presents with gestational transient thyrotoxicosis. What is the management? It is symptomatic and supportive management.
Yes. So what is the option here?
It will be option
I guess.
M, sir. Provide supportive management only.
Yeah. Okay. So the
Yes.
questions are over. So take home message is that preconception TSH goal less than 2.5 LT4 immediately after pregnancy confirmation. Increase thyroid dose. We need to do propylthiouracil is preferred in early pregnancy. We have to switch to propylthiouracil from carbimazole before 10 weeks. TRAB more than 3 times, there is a fetal risk. GTT, no ATDs are required. Postpartum thyroiditis, if you diagnose in a toxic phase, beta blocker will be required. Hypothyroidism state, you will start LT4. FNC is safe in pregnancy. Surgery, second trimester, if required, 14 to 22 weeks. Okay. Severe subclinical hypothyroidism is TSH more than 10. LT4 increase immediately on pregnancy confirmation. Monitoring 4 to 6 weeks till 20 weeks. Now, if you have got a TPO antibodies, you don't have to test these antibodies first thing routinely, and no LT4 is required if the patient is Q thyroid. For Graves' disease, PTO is in early pregnancy, and TRAB has got a fetal risk. Then postpartum thyroiditis, a hyper phase, there is a beta blocker, hypo is LT4. Nodule, FNSC is safe, and surgery is in the second trimester. Okay, so that finishes the whole guideline. Thank you, doctor.